by far and away the most number of papers you're going to be interested in are therapy papers. Papers that come out in a journal article that have to do with a therapy of something. And so today we're going to talk about what are the issues that we should consider in our minds about a therapy article. So to do this, I want you to go, let's see, Nikki, where might their EBM primer be? Is it on D2L?
Yeah, it was posted.
Go to your EBM primer. I think it's probably on D2L. And open it to therapy and go all the way through to the end of therapy, and there'll be a paper, there'll be an article called the Dementia Antipsychotic Withdrawal Trial, DART trial. It's at the end of the therapy section. Has anyone found it?
Okay. Is it from the original EBM? Or you have this one uploaded
No. It's the EBM primer on D2L. It has nothing to do with this lecture.
It's on page 12.
On page 12. So we're going to use this article to talk about evaluating a therapy article. And where would you turn in this article to try to figure out what our question is was this trial validly designed? Where would we go in this article to try to figure that out? To the methods. So turn to the methods. Should be on the second or third page. See it? And read the methods. I'll just give you a few minutes to read the methods. Once you're through with methods, read procedures. Okay, everybody through reading those two? Okay. So we'll come back to those two sections in just a minute. So for therapy articles, there are levels of evidence. The strongest evidence is a meta-analysis. A meta-analysis is where somebody has asked a specific question about a therapy or about any question, and they've done an exhaustive literature review. They've set up some criteria for which articles are in, which articles are out, and then they combine the outcomes of all these articles. So if the outcomes are means, they combine those means and redo the stats. That's the strongest evidence because it takes into account all the randomized control trials that are out there. Systemic reviews of randomized control trials is a similar process, except it does not redo the statistics. A systematic review tries to find all the articles, and then the authors who are doing this study go through and read them and talk about them and try to make some conclusions about them, but they don't redo the stats, okay? But again, it's a look at all the studies that have been out there, so it's stronger than other stuff. Randomized control trials are the next level of evidence. Then cohort studies. What's a cohort study? Cohort study is a retroactive look at some data. So you take a cohort of people and you look backwards to see if they were exposed or not exposed, if they developed something or didn't develop something. You might say, let's look at 100 fifth graders in Oklahoma City public schools and compare them to 100 fifth graders in the Dallas public schools and see if there's a difference in Oklahoma City cohort versus the Dallas cohort in anxiety disorders at the end of middle school or something. Case control studies are less powerful than cohort studies. Case controls are the following. I'm interested in a particular parasite that shows up in some people with diarrhea. And so I go to the lab at my hospital and I say, I want you to refer to me every stool that you examine, every stool that's sent in to you with a request for a right stain in a patient with diarrhea. I want you to report to me every patient you find with this particular parasite. And then I go over there after 3 or 4 months and they've got 16. Not very many, because this is a very rare disease. But I want to try to figure out why these people get this disease, so I go out and look for a control group. I go out and look for people who are matched for sex, age, and any other easy to match variable that I think might be important. Okay. So this is a case control. Every case I'm finding a control for. And then I go and set up an interview or a questionnaire or something and collect some data to see if I can make any sense out of why these particular people get this particular parasite. It's not real strong evidence, but it's a way to get started in a field where the disease is rare and you want to know something about it. Individual case reports, then, and the weakest probably is individual case reports. Expert opinions absolutely useless, basically, most of the time. Okay, so randomized control trials. If you're going to do a meta-analysis or a systematic review, you're probably looking only at randomized control trials, because randomized control trials are the most powerful way to look at a therapy. Okay, and they're randomized for what reason? So we can get rid of bias. The known and the unknown biases, if we truly randomize them, the known and the unknown biases are equal in each group, or as close as we can get them. And then we talked about this, I think, the last time I spoke, about concealment. This is also called blinded, so neither the patients nor the investigator know which group they're in. And we look for computer-generated assignment at some distant location. Okay, minimizes bias. Okay, here are the questions about whether or not this study is valid, and we find the answers to these questions in the methods, in this particular paper, in the methods and the procedures. Was the assignment of patients to treatment randomized in the methods you just read? Yes. Were they concealed? Yes. They were concealed because they were done on a computer in Oxford, and yet they were studying 4 different geographic locations in England, right? So this is the way we want it. This is very nicely blinded. Were they blinded? How did, were the patients and the investigators blinded? How did they do that?
They made the pills.
They made dummy capsules, and they put the real drugs and they put the placebos in the same looking tablets, or capsules or something, so no one could tell what they were taking. Very good. Were the groups similar at the start of the trial? Did you find a table that had those listed? I think usually table 1. There's a table somewhere. Oh yeah, on page 15, there's a table that has age, visual hallucinations, delusions, cholinesterase inhibitors. Now they didn't do p-values, but you look at each variable and you look at the numbers and see if they're pretty close. They're really close. And so what they've done in this table is they've figured out what variables they think are important in trying to make sure that the outcomes aren't due to some other variable. So all the variables that might affect it, they've got in this table. And this table shows that these groups are pretty darn similar. Good. Follow-up of patients sufficiently long or complete. What's the question here? What's the question they're trying to answer? If a patient has Alzheimer's disease and they're on an antipsychotic medication, if you continue that for a year, do they die sooner than if you stop them? So they're trying to figure out what is the survival at 1 year in people on antipsychotics with the diagnosis of Alzheimer's disease. What's the problem here? The clinical problem is the patient's got Alzheimer's. And they got bad Alzheimer's. And why would they use an antipsychotic on them? They don't have psychosis, they have Alzheimer's disease. Why would they be using an antipsychotic? Because they're crazy and they're doing weird things and they're walking around and they're being weird and they're disturbing everybody else in the environment. You want me on some Thorazine, don't you? So antipsychotics, these major tranquilizers, are used frequently in people who act like that, in the hospital, in nursing homes, in living facilities, because it's creating havoc. I mean, it's crazy. It's creating havoc. So they use haloperidol, reserpine, not reserpine, esaperidol. Major tranquilizers is what antipsychotics are, okay? But then there's been some hit and miss questions that maybe they're killing people. So we want to know, are you better off in terms of mortality if you stay on the drug or you stop the drug? So they randomize them into 2 groups and they take them off if you're randomized in the control group, and you keep them on if they're in the experimental group, right? Was the follow-up long enough? A year.
2.
To answer that question, you just kind of have to, it has to be a sort of a clinical judgment. And they apparently, their clinical judgment was that a year probably is long enough, but let's go ahead and look at them for 2 or 3 or 4 years just to see what happens, right? So they kept following them after the 1 year. They thought that 1 year was long enough. Were all patients analyzed in the groups to which they were randomized? What's the question there? What are we looking for? We're looking for follow-up, but we're looking for some language in the methods. Intention to treat, ITT, intention to treat. Were these people analyzed on an intention to treat? Yes. There were 2 groups. They did it twice. They did it on an intention to treat basis, and they did it on a modified intention to treat. So they have ITT written in there, and they have small m ITT. They don't explain what the small m ITT is, but where is that written?
Under statistical analysis.
Oh, not until you get to analysis. Yeah, it's all over the statistical analysis. So what they intention to treat is what you're looking for. You're just sort of scanning through there, reading this stuff real quick. Did they analyze them on an intention to treat basis? That means that everybody who was placed in the experimental group, regardless of what happens to them over the next year, gets analyzed in that group. Everybody in the control group, no matter what happens to them over the next year, gets analyzed in that group. So, they did that. Were the patients, clinicians, and study personnel kept blinded to treatment? Yes. Were the groups treated equally apart from the experimental therapy? We don't know. They didn't really speak to that. They didn't really speak to that. So we don't know for sure if they got other drugs that might have interacted with the drugs they were on. We don't know very much about the other things going on. So that's really the only thing that we're a little bit unclear about is were there any confounding variables? But it's a
This is kind of random, but whenever there's a study done like this where they take a patient off a medication that they're already taking, does that just get determined by the patients who they or their family sign them up for that, and then the board that approves that study?
yes and yes. The question, it's a good question. The question that's really bothersome is if a year is long enough to see a difference between being on and being off, should there be a washout time period? Should you take them off and wait 3 or 4 months before you start the study, you know? Because they did have to take some off, and 27 patients didn't come off. They stayed on because of behavioral problems or a variety of things. So that's where it starts getting a little bit messy. It's not completely crystal clear. And the washout thing is kind of an interesting question. If they were on it for the last 2 years, are they already set up for nothing? Okay. These are the questions we have to answer up front to decide, is this enough to go ahead and look at the results, or should we trash it? Most of the questions were answered appropriately, so at least my view is we ought to look and see what the outcomes were. This may not be God's word, this may not be the truth, but it's designed pretty well, right? So we'll stay with this one a while. And then the next question is, now that you've decided that it's validly designed, what's the magnitude of the effect? And this is, the magnitude of the treatment effect is the difference between the two groups, between those who are treated and those who are in the control group. And there are some terms that you have to get used to: relative risk reduction, hazard ratios. We're going to talk a little bit more in a few minutes about non-inferiority trials. And then how precise was the estimate. Okay? So look at the statistics and read through that one. No, don't do that. Look at the results. Read the results. We're going to spot on the statistics. We're going to assume that they know what they're doing with the statistics, because we're never going to be able to critique that well enough. Good. So, two things on this slide that you've got to remember is what are we looking for in the results for the magnitude of the treatment effect. We're looking at relative risk, we're looking at risk ratios, and we're looking at hazard ratios. Those are the things that tell us the magnitude of the treatment effect. How big is the treatment effect? The 95% confidence interval tells us how precise that effect is. How precise are the outcomes that we're looking at here. And the narrower the confidence interval, the more precise it is. So what you're doing is you're looking at the 95% confidence intervals and saying to yourself, is that narrow enough for me to like this? And you just have to get a lot of experience at doing that. You won't know the answer to that question very well until you've done a bunch of articles or until you've practiced medicine a long time. Preciseness of the estimate is the 95% confidence interval. That's a little easier to deal with. Okay, so here is a made-up calculation. This has nothing to do with the paper you're reading on the book. But here are some definitions. Event rates, control event rate, experimental event rate. I think we went over this the last time I spoke, didn't we? Where the relative risk reduction is the 2 divided by the control minus the experimental control. Absolute risk is just what it says. It's just the absolute difference. In this case, 1.4. And then the number needed to treat. How many people, in this particular case, we would say, how many people do I have to take off of these antipsychotics to save a life? In this example, it would be 72. All right. Hazard ratios. Now, when the endpoints of a study are reported as hazard ratios, as the one is in your paper there, we know that the hazard ratio represents a ratio of survival of some bad outcome at some specific time in the study. Now, how hazard ratios are calculated is too complicated for us to worry about. Okay? Just too complicated for us to worry about. But hazard ratios are used when you're looking at the effect of some treatment at a specific point in time during the study. They collected data on these people for 3 or 4 years, but they collected, their primary endpoint was 1 year. So they used hazard ratios. If the hazard ratio is 2, okay, a way to think of hazard ratios is, the hazard ratio is always in relationship to the experimental treatment. So in this case, the experimental treatment is keeping them on their medicine. The control is taking them off, right? If the HR is 2, it means that one group was twice as likely to die as the other group, or well, it depends on what the intervention was. In this particular, in our case, it would be a hazard ratio of 2 would mean they were twice as likely to survive if they were on the treatment than if not. If they had a hazard ratio of 0.58, it would mean that one group was a little more than half as likely to die as the other half. Or 0.5 meant that they were a little more than half as likely to die as the other group if they were taken off the medicine. Now the hazard ratio in your paper was 0.58, and that's in response to the survival curves. Right? Those, I don't know if you looked at those, but there are Kaplan-Meier survival curves, and so they're doing a hazard ratio to see what your survival is at 1 year. So if you're 0.58, that means you're a little more than half as likely to die or survive, half as likely to survive if you're in the experimental group. The thing that's most difficult about this part of the outcomes is you have to pay close attention to which is the experimental group, which is the control group, and how are they writing and talking about the results. Okay? So you're a little bit less than half as likely to survive if you stay on the medicine in this particular study than if you got taken off. But you can't ever go back and look at the primary numbers with a hazard ratio and make any sense out of them. With relative risks and number needed to treat, you can go back and do some of the math, but not with hazard ratios. It's too complicated. Odds ratios. Odds ratios are done in retrospective studies. Relative risks and risk ratios are done in prospective studies. So it depends on whether you're looking forward or you're looking backward. If you're looking backward, you're doing odds ratios. And you calculate these on the 2x2 table that we went over last time in using different formulas. So cohort studies and systemic reviews are usually reported as odds ratios. If you see your report coming out as odds ratios, you're probably dealing with a retrospective study. This is, we went over this one before, where we turn odds into probabilities and probabilities into odds, and we just have to memorize that equation. An odds is equal to the probability of 1 minus the probability, and the probability is equal to odds over 1 plus the odds. And we just have to memorize that and remember how we calculate and move back between odds and probabilities. Now, non-inferiority trials. What's happened, I think I mentioned this last time. What's happened is that there's so many new drugs out there that a drug company comes up with a new drug. They don't want to have to compare it to a placebo, because it's not going to be easy to find people who are suffering from some abnormality and they sign up to be randomized to this new drug versus a sugar pill. They're just not going to be willing to do it. So it's going to be hard to get the job done. So what they'd rather do is compare it to the drug that's being used currently. And the FDA has said what you have to do is you have to show that it's not inferior to the standard drug. If you can show that it's not inferior, that's not to say that it's equal. It's not equal. It's non-inferior to the standard drug. So what happens is the investigators say, okay, we're going to try this new drug against a standard care drug, and we're going to decide, just based on logic and clinical experience and what we think doctors will buy, that there should be a 1%, 2%, 5%, 10% difference in the outcomes of the two groups. And they arbitrarily choose that difference or that margin. And then, after they got all their data done, this endpoint for the investigational drug must be compared to the lower limit of the confidence interval of the performance drug, of the drug that is the drug that is standard of care. So you remember the 95% confidence interval is the mean plus or minus a number that's below the mean and a number that's above the mean, and that would be the 95% confidence interval, meaning that if you redid this experiment 100 times, 95% of the time it would come into that range. So you take the mean of the investigational drug and compare it to the lower limit of the 95% confidence interval. That's the safest way of looking at it, and that's what the FDA demands. So its mean must not be lower than the lower confidence interval of the standard value. It ought to be somewhere in that range. So the take home here is, what is the relative risk? What are the things that, what are the words you're looking for that are the margin of effect? What is, how big is the effect? And yes, risk, relative risk, hazard ratio. How do you determine how precise that effect is? That's the 95% confidence interval. You have to study the methods to figure out whether they validly constructed it. And then you're ready to ask a whole new set of questions, which are peculiar to your practice and your patient that you're trying to use this on. Is our patient so different from those in the study that the results cannot apply? What would we think if we were if we had a practice in Oklahoma City and we're looking at a study that was done in 4 different regions of England? Are those so different that we couldn't apply it in our population? It's hard to know, isn't it? Probably not too much, unless you happen to be in a practice where 99% of your patients were African American, or 99% of your patients were Native American, or 99% of your patients were Hispanic. Those might be different populations. I don't know if they are, but they might be different populations from those of rural England, and so you'd have to wonder, you'd have to ask that question in your mind. That's as opposed to asking it in your foot. Is the treatment, I hate it when people say shit like that. Is the treatment feasible in our setting? So that means, is the drug available? Is it reasonable cost? You know, can they get to it? What are our patients' potential benefits and harms from the therapy? And then, what are the values and expectations? This is the whole business of patient-centered care. And it speaks quite loudly to the paper that I just presented you with in your manual. So we know that people with Alzheimer's disease, they don't have a really good prognosis in terms of life expectancy already, just with that diagnosis. They have a shortened life expectancy. If we treat them with antipsychotics because of behavior, we're very likely to hasten their death. The question is, what is it we're trying to accomplish? You know, if you have a family who's taking care of granddad at home, and he's throwing plates around the living room, crashing, throwing plates into the lamps and literally causing havoc. And they refuse to put him in a nursing home, or they refuse to put him in they don't have the means to put him in an Alzheimer's unit. How do you approach it? You tell them, your job, remember, your job isn't to make everything all right. Your job is to inform them as to what the data are. You got to do the best you can under the circumstances you can. So if this were the only data, you would say, well, there's been a study where they took people with Alzheimer's disease and kept them on antipsychotics. We can control them. I can almost guarantee you we can control him with a high enough dose of haloperidol. It's a major tranquilizer. It'll just zoom down. You just keep increasing the dose until he gets quiet. On the other hand, it might hasten his death. Now the family has to make a decision. Are we willing to do that? Or are we wanting to just throw all the china against the wall until all the china's gone? Or grab my wife's head and smash it into the plate glass window? There's no telling what might happen. The point is this. The point is our job is to inform the family as to what the data tells us, and it might be an acceptable thing to put him on major tranquilizers until he dies. We know damn good and well he's not going to just wake up and start writing poetry. So those are values, expectations. The patients are involved in that decision as well as the families. So sometime in the near future, I don't know exactly what date it is, you'll be given a therapy article, and you'll be given that table of questions to go through. You'll do it like we did today. You'll go to the methods and results and try to understand. You'll answer those questions and write out your responses to those questions, and then you'll get together in a small group and discuss it. Did you get together in small groups and discuss the diagnostic article?
Mm-hmm.
What was the paper about?
Ultrasound.
Was it, for most of you, did you learn anything at the discussion? My experience, I'll just tell you what my experience is. My experience is that I read those methods and I answer the questions, and then I get in the discussion with a group. This happens in Journal Club, for instance. I ran a Journal Club for internal medicine residents for like 10 years. And almost every time we'd get in the Journal Club and the residents would make comments and ask questions that I'd never even thought of. And commonly, they brought up questions and issues and thoughts that changed my answers to those questions. I went ahead and did those questions on every paper we talked about. But what that means is that I'm not very good at doing this. I read these methods pretty fast and answer these questions pretty fast. Why? It's not a very efficient use of my time. It's not a very efficient use of your time, right? To try to spend forever trying to analyze an EBM article for one discussion and a little bit of a grade isn't a very efficient use of your time. It's not that you should get all the answers right. It's that you should go through the process and know how it's done. That's what we're really after here. So I would expect you to probably learn something at those small groups, because different people will be thinking about different things when they're reading those methods. Sometime in the near future. We don't know yet exactly when that's going to happen, right? Questions about therapy articles? Okay.
I have a current event question for you.
Current event.
What are your thoughts on the new law that was just signed, the Right to Try Act?
I'm not sure I know what it is.
So they just signed a law,
In the state of Oklahoma?
No, President Trump, and it's saying that patients who have these certain diseases, they can try.
Oh, trying a
medications.
new drug. Oh, yeah.
I just wanted to see
Yeah,
what you
I
thought
didn't
about
know
it.
that they had signed it. It's a big time question. Big time question. And the answer to the question differs if you are outside, looking in as FDA director, than if you are married to a 38-year-old with astrocytoma. And so, like everything else in our society, what it will do is most likely only affect people who have a lot of money. Because the pharmaceutical companies who are in the process of drug development, which is what you're talking about. You're talking about experimental drugs. First of all, you don't have a right to it, you have a right to ask for it. So the drug company doesn't have to give it to you. And if they give it to you, they're hesitant to do so. Because, they're afraid you're going to give it to you, they're going to die anyway. So, they're hesitant to do that, but you can pretty much be sure they're not going to give it to you free. So like everything else in our society regarding healthcare, it'll be only the wealthy who can get anything out of that. Most be my guess. So why is David not circumcised? Anyone figure that out?
No, but I know that his hands are bigger than a normal person's hands, so when you look up at it, it looks symmetrical.
That's true.
That's what I got for you.
That's true.
I've also heard it's very anatomically correct.
Yes.
Very anatomically correct. Yeah. And what's remarkable about that to me is that he's almost three times the size of a normal man. I don't know how tall he is, maybe
I think
17
he's like-
feet?
No, I thought it was like 8 or 9.
Oh, no. I guarantee he's
Oh, he's
at least twice.
Yeah.
He's huge.
He's bigger than that.
17 feet. So, that has nothing to do with anything. Except that if you're sculpting in 1500, you're sculpting a 17-foot man. To have him come out anatomically, proportionally correct is unbelievable. He's up on a ladder or scaffolding or something doing this. You think he's too stupid to know that Jewish men are circumcised as babies? No. Be pretty easy to circumcise David on a sculpture. This wouldn't be hard. It's not that his penis would fall off if you took that skin off. Who was paying Michelangelo to do his sculptures, huh?
The Roman Church?
Well, yes. Members of the Roman Catholic Church.
Yeah.
Members of the Roman Catholic Church, they were called Medici. They were the Medici family. And in the 1500s, Roman Catholics were not circumcised. Circumcision was a religious thing more than it is today. People are circumcised today just because everyone else is circumcised today, I guess. I don't know why people circumcise their babies.
It's a hygiene thing. So my sister said about her kids.
That's what people say if you ask them. But what they really mean is, well, I want him to look like Dad.
Doesn't it decrease the risk of?
The risk of what? Maybe. I can tell you that all the studies that have been done on that are not big enough to draw any significant conclusions.